Hey everyone, I'm John Lynn, the founder and chief editor at Healthcare IT Today. We're excited to bring you another in our series of interviews with top leaders in health IT. And our guest today is Dr. Tom Kelly. He's founder and CEO at Heidi Health. Welcome, Tom.
Yeah, hi John. Thanks so much for having me. I've seen some of your videos before, so pleasure to be here.
Awesome. Well, we've done a lot of ambient clinical voice as part of our series. We like to introduce all the different ambient clinical voice companies with a series of similar questions. So it'll be fun to hear how you answer them. But before we go there, tell us a little bit about yourself and Heidi Health.
Yeah, for sure. Yeah, best for last, the one to remember.
Is this the
Uh,
one? That's a good question. It might be.
um, yeah, so I'm a doctor by background. I studied math, so I was always kind of interested in other things. And yeah, I think I've been obsessed with AI since 2015, 16. There's like airport chatbots that everyone used to hate that, you ask like, oh, I've missed my flight, can I change it? And, so we experimented with those for med student education a long time ago. And I always thought they were a lot better than I realized. Like, thought like if I just got it right, I might not be able to know that the AI was running the chat. So yeah, been following the space ever since, and started the company in 2019, and been building different AI tools, not just note taking for clinicians since then. Yeah.
That's awesome. I mean, I think people love the overnight success story of ambient clinical voice or ChatGPT or, whatever you want to call it,
Yeah.
generative AI. And yet, I remember 25 years ago, I was in college and heard about AI, right? So it's like we've been working on this a long time. It didn't just
Yeah.
happen overnight. But, talk to us more about the story behind Heidi Health and kind of where you're at today as a company.
Yeah, I think like for me the main like pain point I had working as a doctor was um just so much of what you do as a clinician isn't really what you went into the specialty to do. So I think I don't know about most doctors, but I think people have this view of what it's like to be a doctor, You walk in the room, you're an eminent, important person, you're, smart, someone needs your help, you gather their history, you figure out what's going on, like some complicated situation. You may modify medicines if it's chronic, or you give them a new diagnosis if it's something brand new. Give them medicine. It's all good. Walk out of the room. Happy days. Cape swings past the door, and you move on to the next one. Um,
Wasn't
yeah.
like
Or
that?
yeah.
They don't need, I mean, they issue
Sometimes.
you a white jacket, not a cape, but
Sometimes it can be like that. But I think what everyone realizes when they actually do it is that there's this massive amount of bureaucracy that comes with the job, and it's fair enough, like you got to get paid, you've got to code your visit properly. If the patient had hypoglycemia or they didn't had hypoglycemia, you get paid an entirely different amount. So now you spend more time writing your note than looking a patient in the eye because you're making sure you're creating the note in the right way for the audit trail, for the billers, for the next doctor that's going to read it. So yeah, I think there's been like an assault on that perfect ideal of medicine from a lot of really record systems and all the administration that has been built up in healthcare. So for me, practically, that was just like note taking, missing like anniversaries and birthdays, spending time late nights in the hospital, writing referrals or forms or things that just built up during the day. It's kind of like a debt that builds up. You do your day, and then there's this debt that builds up of tasks that you have to do. Um, so I've always been passionate about trying to get to that platonic ideal of what a great any clinician really wants to do. Um, and yeah, sure, note taking is one part of it, but there's lots of other tasks as well that I think AI will help clinicians get away from. Even things like yeah, like filling forms, creating other documents, note taking, drafting and searching through the record. Clinicians spend a long time gathering relevant context, looking through past visits, trying to figure out like what exactly did I do last time, what's happened for this person so far.
what's happened since.
Yeah, exactly. Uh, or also things outside of the visit, like you get calls from patients or other doctors clarifying what you did or why you're referring them, or patients have questions about your plan. Even though in the room you still explained yourself really well, but you just fair enough. Like not everyone's not going to remember word for word what you said. Um, But now with some of these AI tools and some of the things we've been building for a while, it's definitely possible to share a patient explainer that the patient can ask questions of, and you can show the transcript and surface exact answers of what the doctor said during the visit. Um, yeah, so it's basically like if I succeed, doctors will enjoy their lives more, and yeah, wear more capes, you know.
I hope we
Yeah.
have more capes in healthcare. But I think what's interesting, you highlighted something that I think is under talked about, which is there's a lot of data that wasn't ever documented that could provide some interesting context. You know, I've had conversations with a lot of ambient voice companies, and they talk about, you know, the blowing up of data, note bloat, you know, a common thing with templates. And I'm like, well, ambient voice is going to make that worse, right? Because we're going to
I
capture
agree. Yeah.
everything, which has a negative side. How do you filter through it, right? Like you said, you're going to need the tools to filter through it, but it also has the positive side because now you have not just what was documented, but why it was documented, you know, based on what was said. That's
Yeah,
interesting.
I agree. Yeah, and part of the magic of great notes, which are hard to create, is like the actually like simplicity and synthesis. Like it's not about having everything. It's about having like the 4 points that matter. So the next doctor. And that's actually like I don't know. So this is controversial, but actually, like the real end state is no notes. Like if something like Heidi is or anything is capturing context, like the record becomes a store of transcripts almost of like what's happening, then like you can still create a clinical note, but for the next doctor, what they need from that source of data is specific to them. So like the act of creating the note is like compressing the what happened into something that you can easily read. But if these AI tools can do that, then maybe the end state is that actually you're just like not having to document as much at all. Like you just walk in, record your session, review for accuracy, approve the record of it, and then move on to the next one. But you're not writing a note for like it'll be a performative act to write a note, you know? Anyway,
Yeah,
yeah.
no, I've said something similar. I said we're not just going to have one note. We're going to have 100 note, one for the patient, one for the nurse, one for the specialist, one
Yeah.
for the doer, one for. But you're right. I mean, essentially, those are views of various data as opposed to
Mm.
notes. That yeah, that's interesting.
Yeah.
Well, let's dive
Um,
into the ambient clinical voice side a bit. You know, it sounds like you're doing some other things, and I think that's where all of this series is headed: is who's going for clinical decision support, who's going for billing, who's going for, you know, et cetera,
yeah,
right?
yeah.
But you know, those are future series. Let's dive into the ambient clinical voice side. How
For
does your
sure.
solution compare to the plethora of solutions out there? I could list them all, but you know, go check them out at healthcareittoday.com. Click on
Yeah.
the ambient clinical voice companies, you'll find them all. But anyway, yeah, how do you think it compares? What differentiates you from them?
Yeah, I think the biggest differentiator is the flexibility of Heidi. So, um, like we have urologists and cardiologists and all sorts of clinicians that build really, really detailed, specific templates. So an example, like we have a urologist who has a template for prostate screening visits. So basically, you know, you do a blood test, maybe your PSA, which is a prostate marker, is a bit high. You come in and see him and basically has this massive structure of the Gleason score, which is a prostate cancer risk score, your like historical investigations, your so like very detailed. And even on individual lines, he tells Heidi how to write that line. Like, I prefer to write the Gleason score like this or that, or I prefer to not include this investigation because I don't think it's important. So this like really high degree of customization. And then one other key feature is we have a context tab where people can paste additional context and other information into the visit beforehand. And the combination of those two things means that even if it isn't like perfectly integrated or they're just picking it up standalone, they can get Heidi to write really, really good notes quite easily. I think the other thing, like, yeah, lots of little features that maybe don't show up in the headline but add up to a lot. So we have like a voice selector, so people can pick from brief voicing to Goldilocks, which is just right, to detailed and super detailed. So, um, yeah, it's like, why is Notion better than Word? It's all the little details about how you can format it and link it and drag and drop and all these other things. So we really want to be like the most beautiful, elegant like software on the UI UX side, and then really let clinicians customize to a high degree. And that's why for us, like basic node generation is actually free on Heidi. It's entirely free. Like we have 4,000 users using Heidi every week just to generate notes for free. Um, and where we charge is really to get like super in the weeds on like exactly how you want your template to work, or if you want to create other documents and next step actions. That's where we make our money. It's not on the initial note, because that feels like a trick that is not is hard to do well, but is not the thing where you want to monetize on. Like you don't want to force people to pay for that. You want them to get used to it, get comfortable, and then once they're like, okay, I really want to see what AI can do. Like I want to fill in my ADHD assessment or my letter or my patient explainer or whatever. That's where we kind of draw the line. Yeah, hope that helps. But yeah, beautiful software and then like really high degree of customization. That's the Heidi difference. Yeah.
Yeah. Well, the a classic freemium model, as they call it in software startup
Yeah,
world.
yeah, exactly.
But I don't know of any others that are doing freemium model in ambient voice. So I think that is a interesting differentiator. So let's walk through the workflow. What does that look like for a clinician? Are they using their phone? Are they using a desktop? Do you have your own app? And then do they hit record? Talk about the workflow that you see, and maybe
Yeah.
you have multiple.
Yeah, I think it's fairly similar to maybe some of the others out there. So I think of it as like, what's your microphone? So there's different microphones you can have. Could be a phone, so you could be using Heidi on a web browser or an app, or you could be on a desktop using a plugged-in microphone. And that's really the recorder. So listening in as we transcribe the visit into transcript and then create your note. That's kind of first step. Then usually clinicians will use it in two main ways. So let's say take the phone, for example. Um, they'll either do like a direct dictation, so like a kind of verbatim style, like I saw John, comma, new line, I referred him for XYZ. So like very like reading out loud the grammar. So they want us to write exactly what they're saying. Then there's another way where you can still dictate. You didn't record the whole session, but you're just going to tell Heidi what you did. So, hi, Heidi, just FYI, I just did a right second toe amputation and it went totally fine. I did all my normal prep. Like, just please fill in the details of my normal toe amputation. Thanks. And then what they'll do is they'll pick a template they've already created for an op note, ideally for that procedure, and then Heidi will kind of fill in the gaps and they'll review that and add it into their record. So yeah, that's like the non-ambient side where you're not recording the whole visit, more of that kind of AI dictate. And then most common is recording your whole encounter. So clicking start as you walk in the room, obviously consenting the patient either beforehand or in the session. And then click stop at the end, pick your preferred template, and it goes ahead and writes it out for us. And yeah, people usually spend a little bit of time messing around with the settings or picking different options depending on the context. So, if it's a note just for them, they might choose brief. If it's a note for another clinician where they want to be more verbose, they might pick the detailed voice option. And then if we're integrated with the EHR, they'll be able to click push to the EHR and it'll send the data back in a structured form. So rather than it being like a free text or a PDF, you're actually sending back like subjective into subjective field, objective into objective, date of birth and past medical history into the right fields. Yeah, so I think that's roughly the workflow. And then sometimes people will come back to those sessions when they're seeing that patient again. So they might ask Heidi to write a quick summary of that, paste it into the context, and then do another session. Yeah.
Interesting. Yeah, well, and we're going to dive into the EHR integration in a minute, but how much of this is actually automated with technology, or are there humans in the background? It seems like everyone's moving towards technology, but there's still a bit of a debate. Do we want to get to the
Yeah.
100% with some human scribes? What's your approach?
Yeah. For us, it's all software approach. So It depends on the really specific workflow. Like we have some customers where there's let's say like a letter workflow or a workflow where someone's kind of like dictated, like on a dictaphone, a letter or something to be sent. So in those cases, it can make sense. Like people can use Heidi like a dictaphone, so they can upload all the recordings, review, but also listen back to make sure that it's a perfect representation of what was said. But I view that as more like, kind of 1.0, like kind of dictation software,
Bridging
not
into the
really.
future.
Yeah, exactly. Like that's more a bit of a historical artifact. Really, what Heidi should be doing in the software is interpreting what it hears and writing the correct thing. And really, what you're reviewing for the clinician or the person who's creating that clinical artifact in the moment is reviewing it for accuracy. That's the most important thing. Because yeah, no matter how good your voice is, like even if you're a human resident in the room, you still sometimes mishear things. So even that's why an attending will look through what the resident's written, because there always needs to be just a step of like, yep, I'm happy with that plan. Um, and yeah, that's where we want to get to. Like Heidi's that AI resident in your room, listening in, writing and drafting what you want. Same idea, like the resident learns from the attending what the preferences are, how to personalize the note, the different lines that they prefer, ways to write the note. Same thing as you use Heidi, we learn from your changes and edits. Um, so yeah, I think like Heidi's the AI resident in your pocket. That's the idea. Yeah.
Yeah,
Uh, but
definitely.
software is the go, I think.
Yeah. Well, and I think everyone's in co-pilot mode too, right? I think we abuse the word co-pilot now, but
Yeah.
there is a human known as the clinician still in the loop. But yeah,
Yeah.
interesting. Let's dive into the EHR integration. How are you integrating with the EHR? Do you work with all EHRs? Where are you at in that EHR integration, which I think
Yeah.
is going to be an evolution as the EHRs open up. But anyway, where are you at now?
Yeah. No, so going really well. So we partner with Redox, which is a integration vendor in the US that helps you integrate into a lot of large systems. So yeah, excited to work with them. Um, and that'll cover off like the larger systems initially. So like we can integrate now through them with like your Epic, Cerner, Allscripts, Athena, uh, and that's really common for kind of large opportunities where maybe they'll pilot it unintegrated, but integration is a really key part. And practically what that looks like for the clinician is kind of two ways. So one is where you can see your schedule for the day or the patients you're going to see or the patients on your list. If you pick that patient, we're reading from the record demographics, but also some information where we have access from the past, so progress notes and other things. And that's being added into that context tab, so it informs the next note. Um, the other thing that you get is once you click stop and the note generates, you can click push to EHR. And so it'll use these structured sections and send it back into the system in the correct sections for your sign off later on. So yeah, I think that's the big systems. There's a big band of systems kind of in the middle, like we call it kind of middle market, where usually they're specific to individual clinician types, not always, but generally. So you might find like counseling systems or audiology systems or like very specific setups for different users. So in those cases, we have kind of two approaches. One is which we're starting to do is we actually built out kind of like Stripe, like an SDK that those systems can add a single snippet of code and add Heidi to their product. So you click a button, it's like Intercom or one of those support agents, it pops up, you can do the whole AI experience inside that system and never have to leave.
Hmm.
And the benefit of that is two-sided. So one, obviously, as a user, is great because I don't have to remember to trigger Heidi. It's just always there inside the screen where I'm working. And the other benefit for the system is that it's actually quite hard to build these AI products. A lot of them have ambitions to do it themselves. So they'll say, "Oh yeah, I'll just hook up to Whisper and Chat GPT, and I'll be good." But actually, like it's quite hard to make it work well. Like there's offline, all these templates and structures. There's just heaps of software in it. So that's what we focus on every day. We've got a whole team just building that. But they can resell it and set the right price for their customers. And we're always in this constant tension of trying to make it like just an amazing deal for the systems to just easily add Heidi for their users. Yeah, so they're the two main approaches. And then the last approach is just opening up our APIs. So sometimes the customer we're working with doesn't use a system um, that has an integration or a marketplace. So sometimes they'll have engineers that will do the work for us. So they'll use Heidi and hook it up to their database or whatever they're using to create the system. But the short answer is yes, we can integrate with everyone, um, do that discrete write back in a structured way. And there's levels to how integrated you can get depending on whether the system is willing to add the SDK into their system. Yeah.
Yeah, absolutely. So talk to us about the clinician and what they have to change anything as they're talking in the exam room? And also, I mean, I think related to this is what's the onboarding and what's the kind of training process for a clinician to start using Heidi?
Yeah. Yeah, why don't I'll start with the first one. So, yeah, changing your behavior in the consult is kind of interesting. So, you don't have to. With Heidi, you can resume your session after the patient's left. So, uh, like if you don't want to change anything about the way you do patient care, you think you've got good rapport building skills, that's totally fine. So you can just record, do your thing normally, click stop. And then it's two ways to do it. One is you look at the note, and if there are missing sections or obviously Heidi couldn't see the way the patient looked or the blood pressure results or, the things that you did as a clinician, you can hit resume and just quickly dictate those as findings. So and again, we tune Heidi to be like a resident, so kind of quite flexible. Like you can, when you hit resume, you could kind of say like, just so you know, Heidi, like although the patient was saying they had chest pain, is actually more in the abdominal area. So that's why I went down this questioning path. Like I'm not actually that worried about like an MI because this person's 25 and healthy. So you can it's not like a very structured dictation because I just think that's more useful. Like if you had a resident in the room, that's how you would treat the human Heidi. So why wouldn't you treat our Heidi that way? So yeah, I'd say most people do that. They don't really change the way they practice. They'll just dictate the findings at the end. But for sure, like I actually think it can be a benefit to the patient if you're explaining what you're seeing, explaining what you're doing. So if you say your blood pressure is 120 over 80, that's great. That's normal, bang on normal. Normal is 120 over 80. So great to see that. Temperature's in normal range as well, 37.3. Like it's just a small change, and the benefit of that is when you click stop, it'll just generate straight in there. Um, Onboarding, I think so for us, one big differentiator as well in the product, you can use Heidi. Like you just go to the website, get started immediately. I know there's a couple like that. So like, your Freed of the world or Nabla of the world are similar. But some of them you can't, like DAX or Health Scribe isn't straightforward, or like you have to talk to a sales team or something like that. So I'd say with us, onboarding is incredibly easy. You literally, you don't even have to sign up. You jump straight into a tour. You can talk to our team if you want help. So we have demos available where you can book time with the team and they'll help you set it up. But if you don't, you can just set it up for yourself or help you pick your first template. And you'll do your first session without a patient in the room in front of you with like a mock script. And you can read it out loud, or you don't have to. You can just generate with an example. And yeah, we find about like kind of 45-50% of people that go through the tour and complete it end up using it in the first month, and about 80% come back in the second month. So it's actually a quite high activation for a group that typically wouldn't use these tools, like I
Typically
think
wouldn't do a single demo. Yeah.
yeah. And I think again for us it's like a philosophy about software, like how it should be. If your product is really good, you shouldn't be hiding it. Like you should be able to use it. If I always worry if it's like the only way to try the thing is through sales, like it feels like there's rent seeking happening. Like I'm trying to be conned into using this thing. So should be able to use it immediately. For sure, sometimes there are features that are better taught than do it yourself. So we do that. Like sometimes for enterprise things or integrations, yeah, sure, talk to us because it'll just be easier for you, less headache if we're doing that work. Even templates, we can set them up for you. But yeah, first impression, you should just be able to jump in and try it. Yeah.
Love it. Well, it helps that it's free, the first part. So,
Exactly. Yeah.
you can just
But actually, but But the downside is sometimes we get like a bad first impression because clinicians are very varied. So, what we need to write for a nurse is different from a cardiologist, is different from a vet, for example. And so we do our best, but sometimes we see comments like, "Oh, like Heidi was so brief for me," or like Heidi was this or that. But it's like, damn it, like you didn't pick the voice setting, or like, you didn't edit
Yeah,
your
you
template.
had an
Like,
option.
yeah, yeah, yeah. It's not Heidi. It's you don't know how to use it yet. But anyway, that's totally fine. It just comes with the territory. Yeah,
Interesting. How about accuracy? I think that's every doctor's concern. I'm sure it would be yours as a doctor doing
yeah,
unfortunately, or at least it seems like the doctor's going to still own the liability, right? So talk to me how you approach accuracy of your solution and how you evaluate how accurate you are.
yeah. So I'll do a small diatribe on why I think accuracy is the wrong metric. But
Okay.
first,
Sure.
we do still take it very seriously. So we have a whole medical knowledge team. I think more than 10 different clinicians in the team now that run through like thousands of test cases on every new release, test it really deeply on all the adversarial cases. Because we see from the data and the feedback we get from our users where Heidi isn't doing well, or areas where people want to see improvement. An example would be like, let's say, a really challenging multi-speaker environment where you've got like kid crying, a mum giving you the history, dad, a resident chiming in, so it's like very messy. So yeah, we kind of run mocks of those scenarios, we record them, and then we run them through and compare historical versions with new versions and see how we're going to make sure not only that there's no regression, but that if there are inaccuracies, that they're kind of safe inaccuracies. Like Heidi is surfacing that uncertainty in the notes so that the clinicians can find that rather than just writing something confidently incorrect, which is the most dangerous kind of mistake. Um, as far as accuracy, I guess why I think it's the wrong metric. I just think for for us, like we'll just lose users if we don't write what they want. If they have to edit more than like 5% of the note, it's like not worth my time. Like I could have just written this note during the visit. Yes, it's a bit annoying. Yes, like I have to type as I go, but that's what we're always up against. Like we're up against them typing it themselves in the visit. And what great doctors do isn't accuracy, it's interpretation. It's figuring out what's going on in the room and what is clinically significant and what isn't. And it's highly contextual. It's not about getting the words right. Sure, it's kind of important, but residents don't pay attention to half the visit and they still write great notes, as they listen to their podcast or whatever. It's more that like, can you figure out what the right thing is to write? So like we are obsessed about making Heidi write what the clinicians want because that's the metric that matters. If we nail a template on a first impression, then they will come back over and over again. If we don't write well the first time, they will just think that Heidi can't do it. But it's not the case. It's just they haven't set it up right. So I think the people that are obsessed with accuracy are the ones that teams that started earlier often I find like yeah, won't name names, won't be mean, but I think historically, like pre-large models, it was really hard to do voice to text well. So that was where all the trick was. So you had to do perfect accuracy because there was no AI to figure out what was going on. You literally had to be perfectly structured and take that and write it in a structured note. But now, like if you mishear like nosebleeds as nose please, like KNOWS please,
Yeah.
the AI will figure out that it's nosebleeds. So yeah, sure, like you can spend all your engineering resources trying to make sure that it hears nosebleeds, but even humans don't get that right. Like there's some level where you reach like an asymptote. But the area where there's a lot of change and opportunity is on the AI processing. Like, can I make Heidi as smart as a resident, figuring out what's going on? Get all the intuitions, the way the voices sound, the different people in the room. Like that's where the challenge is. So yeah, we are very accurate. Like people love Heidi. They give us great reviews. We've got like 4.8, I think, on Trustpilot. So we should care about it, but I care about writing what they want. I don't really care about getting every word perfect. Because I just don't think that's the thing that leads to the best note. Yeah.
Yeah. Yeah, I mean, obviously, after all these interviews, I've realized there's layers of accuracy. You know,
Mm,
there's accuracy of the what was said, there's accuracy of what was meant, there's accuracy of what was coded, and what was,
yeah.
I think that's what we're going to see play out is, and you're adding another layer, which is, accuracy of the intent of what was meant to be documented by the clinician,
Yeah.
which is, another layer of accuracy that's interesting. So, yeah, I mean,
Uh,
it's going to be interesting how it evolves. That's for sure.
yeah. And like, I don't know, like I'd suggest for some of the viewers who are worried about accuracy, when we do this demo as well. So there's some large models that are available, like Whisper and DeepGram has some great models as well. And if you try those products, like honestly, you can't, it's better than me. Like if I was trying to write what I was hearing, I couldn't do a better job than that model. So it's almost like they've got the best listener in the world and they've just already built it. So that's why I'm a bit skeptical of like how much you can push that on the technology side. Like, as if like there's some error rate, fixed error rate you can't overcome. Um, and I don't think we're that far from it. But the writing, yeah, huge variance. Like depending on how you tune the AI, the templates, the different structures you create is a huge variance on how the products write. So yeah, that's where we spend a lot of time. Yeah.
It's interesting that, and not to dive too much into this, but I believe that accuracy is going to become a commodity. They're all,
Yeah.
all of them that are reasonably funded, and which most of them are,
Yeah.
they're going to be at the 98, 99%. And humans can't tell that 1% difference, right? So
Agree.
it's
Yeah.
going to be other stuff, the integration, the clinical decision support. Anyway, that's where we'll head in our future series.
Yeah.
Anyway, we'll
Yeah.
see where it heads. So you talked a little bit about specialties, but do you work with all specialties? Do you have some that you're better at? Talk about kind of specialty specific efforts.
Yeah. Yeah, so we're quite explicit. So we really want to be a horizontal tool. So that's like a software term for any kind of clinician can configure it and set it up themselves. Um, Definitely we see a skew towards, I think of it in kind of like three buckets. There's primary care, because they just see so many patients. So their admin burden is high. Mental health. So mental health, it's just it breaks the flow if you're typing during a deep and complicated conversation with the patient, and also the note is really critical medically legally. You want to write something very good. So that's very popular. There's also proceduralists, which is basically like anyone whose hands are full. So I can't type and be a podiatrist. I can't type and be a physiotherapist. I can't type and be a dentist or a vet or a pediatrician because I'm doing things during my clinical encounter. So we see that group overrepresented as well. And then probably the fourth bucket is like where the value of this person's time is really high. So that's like your surgeons, dermatologists, ophthalmologists, where um, it also it's not so much about the money. It's more just like they have a lot of procedures that they do that take a lot of time. So their admin time is like an hour or two max a day, probably less. It's like an hour or two a week if you're lucky. They just always want to operate. So for them, every like even if you're saving them 5 to 10 minutes a day, that's a huge leverage over the week. So yeah, they're the four buckets we see. I think this is just a general problem with all these systems. I think the longer the visit, the more complicated the meaning in the session, the harder it is to write well. So psychology and mental health is the most challenging by a wide margin because mental health is not in the words. It's in the way it's said, the intonation, the speed, pace of the person talking, their non-verbal communication. Like, do they have a flat affect? Are they like really engaging? Are they wearing pink hot shorts on like in the middle of winter? Like, that's the that's the way that mental
They may
health
not be
can.
vocalizing it either, right? Because they don't
Yeah,
claim the fact that they're wearing pink hot shorts in winter and shouldn't.
exactly. And it's hard. Like, the manic patient could probably have a transcript that looks kind of similar to a normal patient, maybe similar to someone who's depressed. It's just that's a challenge. So the way we get around that is with the context pre-visit and then giving the clinician latitude to dictate to Heidi the things they couldn't say during the visit. And I think that is an area where I am interested. So we're starting to work in like voice markers and other audio based.
Hmm.
Basically, like, can we listen to the pitch and latitude and like the style of speaking and get measurements on that, not just the words that are being said? Because that to me is kind of interesting. Like there's a whole field of audio diagnostics and like diagnosing COVID with a cough and all this kind of stuff. And that is interesting to me because as a doctor, seeing is important and hearing is important as well. Like if I can hear that they're breathless in the way they're talking, even if they're saying stoically that they're totally fine, but they're telling me about their shortness of breath, I intuitively start feeling like maybe this is a bit worse than Joe the farmer is saying. So yeah, that's an interesting thing to explore.
Absolutely. I remember I was working in a doctor's office, implemented their EMR, all that. I
Mm.
walked in and I had a cough. I was going to a conference and he wrote a script and said, take this, you'll be fine. And I was like, wait, don't we need to go to the exam room and, like do the
Yeah,
whole role? And he's like, John, I heard your cough. I heard the tone. Like I
yeah,
heard
yeah,
he's like, I already diagnosed you. You're fine. Now get out of here. And I was like, oh, I learned exactly what you're talking about. It's
yeah,
fascinating.
yeah.
So
It's super.
go ahead.
I was just gonna say, yeah, those like we call them heuristics, like the way, like, and it's not, it's quite cool. Like the absolute best doctors, like my favorite doctors, it was all in like the walk to the bed, or like the walk, or like getting them up out of bed, like that told them everything they needed to know. Like they were almost like non-verbal. They didn't even need to take the history. It's just amazing. Yeah.
It is amazing. I have to ask this one because if they couldn't tell, you're from Australia. You talked about the bang on blood pressure. Do you handle Australian English versus US English versus UK English? Because
Yeah.
bang on, I don't think we're saying in the US, but would Heidi be able to handle that? And you can
Yeah.
hit Spanish too if you want, since that's a popular one, or other language.
Yeah, yeah. So we're lucky. So the models that we do use for voice to text are regionalized. So we have Australia is usually the one that misses out. Unfortunately, a lot of the big companies we work with don't build models for Australia. But yeah, US works super well. UK works very well too. I think doctors usually have like a kind of formal Australian tone. Like I'm being more friendly, but it's a little more neutral. But the AI models like Heidi's AI is really good at figuring out because we include country and region and type of clinician in that. So it's honestly unbelievable how good they are at figuring out what's turn of phrase and different jargon and vernacular that gets used. Because yeah, some of the more regional states in the US or in the UK, some of the accents are very strong. Like for me, like
For
it's
sure.
hard for me to follow if someone's talking really quickly. So yeah, it's amazing. Like I said, models are better than the humans sometimes. Like if I was listening, I couldn't write this transcript as well as Heidi can. Yeah.
Interesting. Cool. Well, I'm sure, as I say on all of these, people are going to want to try it out, and luckily it's free to try out. So, where can
Yeah.
people go to learn more and get a demo?
Yeah, it's HeidiHealth.com. Heidi, just the girl's name, Heidi. And yeah, you can try it for free. The note gen is completely free, so there's no fee forever. That's never going to change. And yeah, hope you love it. If you don't, just message us on the chat page and we'll help you set it up because that's most likely what's going wrong.
Awesome.
Yeah.
Cool. Tom, I appreciate you taking time to talk with us and share about Heidi Health. We're excited to see how this continues to evolve. And thanks everyone for watching and listening. If you want to find more great healthcare IT content like this, be sure to check it out, healthcareittoday.com, or search for Healthcare IT Today on your favorite podcasting applications. Thanks, Tom.
Thank you. Thanks, John. Thanks so much.